As providers, we can help GBV survivors who are experiencing suicidality or suicidal ideations by ensuring good coordination between providers. So that's not only coordination between GBV and MHPSS, but possibly coordination between other actors such as protection and healthcare providers. It's essential that we are supporting the survivor by helping to provide them with support, but also put in place safety measures. So we can also help by coordinating with MHPSS actors when we're conducting a safety assessment with a GBV survivor, or we can also have MHPSS actors reach out to GBV actors to request support when responding to a GBV survivor who is at risk.
To maintain a do-no-harm approach, the number of staff involved in a coordinated approach should be kept at a minimum, with a designated focal point as the survivor's main point of contact. This also helps to reduce the risk of survivors having to repeat the story.
We can try to promote or cultivate intersectional linkages to support awareness raising and prevention. And lastly, we can work on increasing our communication within the community, raising awareness on what services are available within the community. And this will help with providing referrals and increasing the entry points for survivors. So hopefully there will be more awareness and more places for the survivors to then seek and access services.
Limits to the survivor-centered guiding principle of confidentiality. If the survivor expresses having thoughts of self-harm or suicide, it is a critical part of the casework and the information on services to also express limits, potential limits that may exist around confidentiality to the survivor, so that they are aware of these limits and the services available for support.
So it's really important to understand the rule of law around suicide. In some countries, it's criminalized. And so depending on how a case is reported, what services are provided, that survivor could be at increased risk.
Legal responses to intimate partner violence and other forms of GBV may serve to criminalize survivors. For example, to protect their children from the abuser's violence. In humanitarian settings, state actors may be party to conflict and/or their capacity to respond safely may be otherwise compromised. For these reasons, the risks of informing police must be carefully considered, especially if acting without the survivor's consent. Ensure GBV and MHPSS frontline workers and supervisory staff are trained on how to respond in a coordinated way with a joint protocol on managing cases of suicidality among survivors of GBV. The joint protocol should take into consideration resources available or not available in your context and include specific to child and adolescent survivors. Do not wait for a case to emerge. Staff should practice contacting and coordinating with each other so that intersectoral relationships and referral mechanisms are already established when the need arises. Include skills for managing suicidality within case management trainings, as well as trainings for other staff who may interface with survivors, including women and girls, center staff, and healthcare workers training to respond to sexual violence and other forms of GBV. See the accompanying guidance note for a list of training and capacity building resources.
Another thing that we can do is have good supervision in place. By having quality clinical supervision available, staff members can work with that supervisor to discuss different cases that they might have, discuss mandatory reporting policies, discuss things such as confidentiality. They can work with that supervisor to practice different skills that they might need in managing suicidality as well. So I think there's lots of ways that we can support MHPSS and GBV staff when managing cases of suicidality.